or if it's the first time you've joined a webinar organized by our group, the team. So the mission and vision of this particular organization is to promote training and education of otorhinolaryngologic surgery in Hong Kong and the Asia Pacific region, to develop strategies, action plans, and training programs for the professional otorhinolaryngologists in the Asia Pacific region, and to provide comprehensive programs with practical value while emphasizing contemporary principles and techniques, and to work with any society, association, or person for the purpose of developing education training. And this year has particularly been challenging. We've had to adapt to the current situation and modify what we're doing in terms of using more online tools, online methods, combined with hands-on experience as well locally to further our mission and vision. And in terms of board members, Professor Michael Tong is the chair of APOST. I also have Professor Simon Carney, who's the vice chair and treasurer. I myself am Secretary General for APOST. We also have Professor Tari Sugimoto, who's a board member, Jernlin from Singapore, Richard Harvey from Australia, Preppa from Malaysia, and Kong Kiat from Thailand, who are also board members of APOST. And in terms of training format, I think before COVID-19, a lot of it was revolving around lectures, dissection demos, and supervised hands-on dissection, while we've been developing a kind of e-learning platform on our website, which we've been working on. But secondary, I think more of a push from COVID-19, we've developed more of our online training, online platform. So we've actually been doing webinars, I think, since May, June time this year, combined with online dissection demos done at a locally and even overseas, and then organize workshops, if possible, at the local level as well by local local faculties as well. So that's a bit of a change in the formats, and it's something that is, I think, around to stay for a little bit. You're also welcome to log on to or look at our website. And we will have more and more material for e-learning platforms. And hopefully some of this will be education material that you can review before joining any of the workshops or even the webinars. And today, I mentioned earlier, the esteemed faculty, and I'm very thankful for everybody who's joined us today. And also our co-organizers and support from CUHK, Olympus, and ARC Laser as well. And this is the program agenda for this morning. So we'll first start off with Professor Taro Sugimoto, NBI, the hypopharynx and oropharynx, followed by Ryo Kishimoto, NBI and laryngology. I myself will speak about NBI and nasopharynx, followed by Dr. John Lee on laser and laryngology. We do have an MCQ quiz for all the faculties, involving all the faculties, but for everybody, after we finish the lecture items this morning, and then we have a Q&A session afterwards. I would be grateful if you could fill out the post-course evaluation afterwards as well. And for the Q&A part, you will see at the bottom right-hand corner of your Zoom, there's a Q&A part. You can click Q&A to leave your questions in the box, and they will be answered following the MCQ quiz. If there's any further contact, if you want to review content on our website, you're welcome to go to the website here, apostent.org. We also have a Facebook page. You can look for APOST Otorhinolaryngology, and a secretariat support, thanks to Bonnie and also Charlotte, is listed below as well. And I will stop there.
So shall we start the webinar?
So I think to begin with, we have a couple of polling questions just to make sure the function is working okay.
Okay.
Bonnie, do we have the polling? Just a couple of polling questions for people to try out. So we'll just have 15 more seconds for everybody to fill out the polling questions. Okay. I think we can end the poll there. I'll pass on to, oh, actually, this is the results. So I guess for the poll, most people joining are general ENT physicians, and the majority have joined APOST courses before, but a significant number have not joined APOST course before. So welcome this morning to the webinar. I will pass the remaining time, well, the session chair, Dr. Eddie Wong, to chair the webinars this morning. Thank you.
Thank you, Jason, for the introduction. So let's start our webinar today. So Professor Taro Sujimoto will give the talk on NBI in the hypothyroid and the oropharynx. Professor Taro Sujimoto, thank you.
Okay. Can you see my PowerPoint?
Yes. Yeah.
Okay. Okay, good morning, everyone. I'd like to talk about NBI in the hypopharynx and oropharynx. Head and neck cancers are generally diagnosed as advanced stage tumors at initial consultation. However, they are becoming to be found in earlier stages recently in Japan. This is the example of 2 or 3 millimeter carcinoma in situ of the posterior wall of oropharynx by upper GI endoscope. You can see this brownish area, and this is the anywhere view of the right hypopharyngeal cancer by upper GI endoscope during operation of ELPS. Also, we can see a brownish area in the cancer lesion. So what is NBI and why NBI? This is narrowband imaging mechanism. So we can see normal light usually, but after using NBI, we can see superficial vessel as brown colored one, and arborescent vascular network as blue colored deep vessel. So this is schema of IPCL and the superficial vessel network in esophagus. We call this intraepithelial capillary loop as IPCL. So this is Inouye's classification of IPCL. In case of carcinoma, of the pattern of this loop changes from normal brown dots in a pinhead pattern to expanding and meandering ones vary in the size of calibers and lose uniformity. This is the IPCL in normal esophageal mucosa observed by ultra-high magnification endoscope. We can see IPCL like the schema.
Not be raised in early disease, and it has not been proven to be useful in mass screening. So IgA-VCA, or the viral capsid antigen, has a sensitivity of 97%, but it has a really poor specificity. And the positive predictive value is only 65%, which leads to this statement here. And the negative predictive value is 95%. So if the VCA is negative, then the patient really has a low chance of having NPC. But if it's positive, it's really not very, very useful. And they do come in tighter levels. The higher the titer, the more likely they have to have MPC. For early antigen, the sensitivity is pretty low, but the specificity is 100%. So the positive predictive value is 100%. So if they have a positive early antigen, they're much more likely to have MPC. However, the sensitivity is pretty poor. So the combination does improve accuracy, but it's in our practice, it's really proved not to be useful. We don't rely on the viral capsid antigen or early antigen, and we don't routinely test for this nowadays. Doesn't help our practice. And also the other thing is they're not very, very useful for surveillance, because once they're elevated, they remain elevated, and there's no change in the levels. So we do have plasma EBV DNA levels, and it's one of the best markers we do have now for nasopharyngeal carcinoma. And it detects minute amount of this cell-free Epstein-Barr virus DNA in plasma, and it utilizes PCR reactions to check for this. And it is very, very sensitive nowadays, and there are next generation sequencing techniques to improve the accuracy of this test, which are being done. And the early studies by Professor Dennis Lowe's group here at CUHK showed that the sensitivity of EBV DNA is 95%, and it also has a very, very high specificity as well. And this leads me on to talk about the Epstein-Barr virus DNA as a screening tool. And this has been done, this was a study done in Hong Kong on 20,000 males between the ages of 40 to 60 who had Epstein-Barr virus DNA checked. If they had a positive test, they were rechecked 4 weeks later to see if they had persistently elevated EBV DNA. If they did, then they were screened by an otolaryngologist of the nasopharynx. Any areas that were suspicious had biopsies taken. They also underwent an MRI to evaluate for subclinical lesions as well. And of these 20,000 patients, if I remember correctly, there's around 30 patients that were positive for MPC. But the interesting thing is most of these patients, or more of these patients, were caught at earlier stage of disease. And we do know that earlier stage of disease is treated differently in MPC and also correlates with survival. So with this screening tool, we may be potentially able to see earlier stage disease of MPC. And if you read the literature over the last 2 years, this is a group from one of the biggest centers with MPC in Guangzhou and the Sun Yat-sen University, and looking at minimally invasive surgery alone compared to IMRT for stage 1 nasopharyngeal carcinoma. And these were patients that refused to have the traditional therapy of RT, and they had very, very strict criteria for selecting patients that would undergo surgery for primary MPC. So it had to be more than 5 millimeters away from the internal carotid artery, and the surgery was done with endoscopic nasopharyngectomy. And if you look at here, the overall survival, disease-free survival, distant metastasis-free survival, which is an important factor, shows the non-inferiority to IMRT. This was not a randomized trial. This was a small cohort. You can see of endoscopic patients, only 10, compared to a matched control group who had IMRT. But it suggests that there may be a role for surgery in treating early nasopharyngeal carcinoma. And remember, all these 10 patients did not have any sort of radiotherapy, so they don't have any other toxicity. And the functional outcomes of these 10 patients were very, very good in this study. This is a more recent study that came out looking at surgery combined with chemo-RT on short and long-term outcomes in early stage nasopharyngeal carcinoma. In this study, I do take a caveat, they do not describe the surgical procedure and select how they selected these patients very, very clearly, and not very, very clear-cut in what terms of surgical procedures they did for these patients. But overall, it showed that they had better survival if they did have surgery as part of the treatment for their nasopharyngeal carcinoma. And also the functional outcomes were better, particularly if we're talking about xerostomia and change in the sense of taste and smell. we need to see the longer-term results in terms of longer-term toxicity in nasopharyngeal carcinoma. And that's something that in our locality, a lot of work we do for NPC patients is actually managing the complications from radiotherapy and the long-term toxicity related to that treatment. So if this is a possibility of de-escalating or even reducing the dose of RT, that's very controversial. It will possibly help relieve or minimize the number of the late-term toxicity with NPC. So what about narrowband imaging nasopharyngeal carcinoma, and how does it play into all of this? So I just want to show a video here. This is actually a study we're doing now, and we're using, I guess, one of the newer flexible nasal endoscopes. And this is a video of 2 patients with NPC. It's still an ongoing study, and this is just the part we're using from the nose. And you can see a comparison between what you see with white light and NBI. Okay. So this is a patient, it does have NPC. It's a pretty subtle lesion. The blood was from a previously biopsy site, which was biopsied about 2 or 3 weeks ago. And this is the newer scope, flexible scope you can use. So it's a good visualization, flexible endoscope. So you can see on white light, there seems to be some ulceration over that area. It looks a little bit abnormal, but there's no obvious bulky mass. Okay, and this is going in just to clean the camera a little bit. And here you'll see us, we'll switch the NBI with the flexible nasal endoscope. So here you see what Professor Sugimoto was talking about. You see some of the loss of the arborescent or the normal vasculature, and this pinkish area is pretty well demarcated. But as the endoscopist goes in, you see this blurring of the camera. So you cannot really get a very, very magnified view of these abnormal vasculature or identify these vasculature with this type of camera. It doesn't have that short focal length and magnifying capability to really look at the vasculature here and really try and define the margins of this tumor. So this is a nasopharyngeal carcinoma here, which is more endophytic, more infiltrative, and less exophytic bulky mass. So I'll move on to the next patient. So this is another NPC, which is more classical. You see a mass in the nasopharynx. And on white light, it's pretty obvious this looks abnormal. It looks like a tumor in the nasopharynx. And you can see some of the dilated vessels even on white light here. The problem is we don't have suction capability, and these patients, you can't really rinse their mouth beforehand or examination this. And if you use a suction catheter in the nose, it's very easy to traumatize and cause bleeding of these nasopharyngeal carcinoma lesions. So it's not ideal to use that case. So if I move forward a little bit. So we switch to NBI. And just to look at the vasculature here. So this is the easiest area to see. It's not covered by circular tissue here, which you do see fairly frequently in outpatient population. They may have a small amount of lymphoid tissue here, and it almost has this hexagonal shape that you can see, and it's pretty normal. But sometimes we also have the fossa rosemola here, and it's not always easy to see in these crevices, particularly for small lesions, and if they have lymphoid tissue, which is blocking your view of the fossa rosemola. So Professor Valantis did a lot of work on the NBI and use of nasopharynx. And he used NBI and white light to compare its use in nasopharyngeal carcinoma. So for white light patients, he would classify them into normal or normal with lymphoid tissue, a low index of suspicion for NPC, high index of suspicion for NPC, or definite NPC. And narrowband imaging, he would classify based on the vasculature, as normal appearance, so the arborescent vessels that you see, or the dilated and or enlarged vessels only. If you see vascular tufts, or if you see both dilated and or enlarged vessels and vascular tufts. And this is the grading system used on the white light. So this would be normal nasopharynx, and this would be, looks like a definitely malignant lesion to me here. So that's how they grade the nasopharynx on the white light under this study. And for the nasopharynx with NBI based on the vessels, for example, here you would see, looks like there's dilated vessels and vascular tufts here. So it probably would be 3 on appearance here. And looking here, this is what it appears like lymphoid tissue. So here you make out these white spots, almost hexagonal shape, and you will see the vasculature here in the nasopharynx is very, very different from what they saw in oropharynx and hypopharynx with Professor Sugimoto's videos. Here you see the perilymphoid follicle vasculature, which gives this outline of the hexagonal shape, and it's very, very typical of the nasopharynx with NBI. And here it would be the dilated vessels that you see on NBI, grade 1. And here would be the vascular tufts that you can see, which are not very, very obvious on white light. And here you would see both dilated vessels and vascular tufts of this lesion here that we use to classify. And the NBI study that was done, we screened 156 patients with abnormal EBV serology. And referred to an ENT clinic. And I know time is running short, so I will move to the results part. So if we look here at the results, this used A, B, C, D, E on white light. A and B essentially is normal for A, and B is normal lymphoid tissue. So it's similar as the grading system before A, B, C, D. Okay. And what you'll see with white light with the different grading systems, it has a sensitivity of 85% to 92%, depending on how you choose your grading. But if you use just suspicious or definitely malignant as positive, you have a sensitivity of 92% and a specificity of 92% again, and an accuracy of 92%. But if you purely base just on vasculature alone with narrowband imaging, depending on your choice, the accuracy was 86.5% if you used dilated vessels or vascular tufts, or dilated vessels and vascular tufts, accuracy of 86%, but the sensitivity was low at 65.9%. Remember, this study was done almost 7 or 8 years ago, so the technology has changed since then in terms of the flexible endoscopes. So taking home the message from this was, regardless of screening for suspected NPC, white light endoscopy must be undertaken, one, to guide the biopsy, and it has a higher sensitivity than NBI endoscopy during this study. And this may be because of the what we determined to be used for the vasculature in NBI. And I just want to move on to the next part. So we also used 4 individual surgeons to compare between surgeons and how they viewed white light and NBI endoscopy, and the correlation between surgeons, both on repeat viewing of images. So one surgeon would look at the images twice, and also between surgeons. So the correlation on white light was highly correlated intra-observer. So if the observer looked at the image twice, he would almost certainly call the same thing highly malignant with white light, but this was moderately correlated with NBI. And if we looked at inter-observer, so between the 4 surgeons, there was a strong agreement for white light, but there was only a moderate agreement for NBI endoscopy. And I think what this means essentially is, if I go back to the end, is that the inter-observer agreement is high for white light, but not so for NBI. And this may be a function because we're trained to look at white light to begin with, so we're much more used to that, and we're having to relearn NBI. The other thing is we don't have a good definition of on NBI of what constitutes nasopharyngeal carcinoma at this point. It's a little bit different from the oropharynx and hypopharynx. So there's still some work to be done to use NBI nasopharynx. And we also did a meta-analysis to look at this as well. And similarly, it showed that white light has a higher sensitivity. There was no benefit of using NBI for diagnosis of nasopharyngeal carcinoma. But to conclude, I think future directions, the technology has improved and imaging has improved. I think it will continue to improve. There may be more magnifying capabilities. The focal length can be reduced. With improved screening, we will possibly see earlier cases of NPC, and there may possibly be changing paradigms in treatment, given these recent 2 studies showing the role potentially of surgery in early NPC, which if we use NBI may potentially guide resections and margins for resection as well. So I'd just like that to end my talk. Thank you.
Thank you, Jason. So I think Dr. Yo fixed his PowerPoint slide. So, and we can move to talk to Dr. Yo and start his talk on NBI in laryngology. Dr. Yo is from Kyoto University, and he's a laryngologist and also a hand neck surgeon. So he will share his experience in NBI in laryngology. Thank you, Dr. Yo.
Thank you, Eddie, for the kind introduction. And thank you, Jason, for changing the order. My name is Yo Kishimoto from Kyoto University, and I'm going to talk about application of nerve imaging in laryngology. So my talk includes some topics. I'd like to start with talking about the laryngeal cancer and then basic principles. And actually, there were some overlaps with the previous talk by Dr. Sugimoto or Dr. Chan. So I will skip some of my slides. And then I will introduce the intraoperative application of nerve imaging. And finally, I'm going to show some images of laryngeal lesions. Okay, let's start with the laryngeal cancer. So the laryngeal cancer is a relative rare malignancy. So among all malignancies, laryngeal cancer is ranked at 22nd in terms of incidence. And in terms of prevalence or mortality, it is ranked as 18th. And regarding the regional difference, it's very common in Europe or America, Southeast Asia, or Western Pacific. Regarding the oncological outcomes of laryngeal cancer, it is not that bad. I mean, the prognosis of early stage laryngeal cancer is very good. I think the 5-year survival rate will be more than 90%. But in the advanced stage cancer, prognosis is not good, even with the multimodal treatments. And also the patient who had the multimodal treatment often suffers from post-treatment sequelae. I mean, the patient who had the laryngectomy complains anosmia, dysgeusia, dysphagia, or constipation. And of course, they need to take out a permanent tracheostoma. And also radiation induces mucositis, xerostomia, loss of taste, dysphagia, and occasionally radiation necrosis occurs. So the multimodal treatment for the advanced laryngeal cancer often deteriorate the QOLs of the with good satisfying QOLs. We need to detect the lesions at early stage and treat them less invasively. Okay, from here, I'm going to talk about the basic principles of NBI. And narrowband imaging, also known as NBI, is an optical image enhancement technology, which was developed and launched in 2006 by Olympus. I will skip this. So in the NBI illuminations, the white light is split into two narrow bands, 415 and 540. And these wavelengths are very close to the absorption peak of hemoglobin. So these lights are absorbed by the vessels. And the shorter wavelength light penetrate into the shallow part of the mucosa, and deep wavelength light penetrate into the deep part of the mucosa. So the shorter wavelength light are absorbed by the capillaries in the mucosal surface, and longer wavelength light are absorbed by the submucosal veins. And reflex was captured and processed and displayed on the monitor, and capillaries are shown in brown, and submucosal veins are shown in cyan. So the NBI helps to visualize the minutest vascular and mucosal patterns by enhancing the contrast. Now, this is an actual NBI observation, and we can see brownish structures here. These are the capillaries in the mucosal surface, and here we can see something moving. So at the magnified view, even the movement of blood cells can be visualized. Then why do we need to be careful about vascular structures? In 1971, Folkman proposed the concept of increased density of angiogenic microcirculation in cancer. This concept has been well accepted all over the world. And briefly, in the tumorigenesis or calcinogenesis, there is a increased abnormal angiogenesis beneath the lesions. So if we can detect the increased angiogenesis or abnormal angiogenesis, it will be helpful for identifying the malignant lesions. And vascular structure and malignancies, relation between vascular structure and malignancies has been well investigated in esophageal cancer. This schema showed the vascular structure in the esophageal cancer, esophageal mucosa. And there is a submucosal vein and branching vessels here. And branching vessels lands in the horizontal plane, and intraepithelial papillary loops originate these branching vessels. And IPCLs lands in the vertical direction in the lamina propria, and finally lead to the intraepithelial papillae. And in the NBI observation, we can see these IPCLs in brown, as a brown structures. And the shape of IPCLs is also important. So in the esophageal cancer, it is reported that IPCLs changes followed by the cancer infiltration, like this. So in the endoscopic exam, to find the very early stage cancer, we need to find the increased IPCLs, and also we need to check the shape of IPCLs. This is the actual case of very early stage superficial cancer. So here is a brownish area, and at the magnified view, we can see the bunch of increased IPCLs, and shape of the IPCLs is very strange. And the abnormal angiogenesis in cancer has been confirmed histologically. In the normal mucosa, CD31 positive endothelial cells sparsely distributed like this. But in the cancer, we can see the bunch of CD31 positive cells like this. These findings or this concept has been applied for head and neck, and Ni and colleagues proposed a kind of classification of microvascular proliferation patterns in laryngeal lesions. It's well organized and it's very useful classification. But as you see, these invasive cancers are very easy to identify. So I think the advantage or strengths of NBI observation will be demonstrated in identifying very early stage cancer or precancerous lesions like high-grade dysplasia or carcinoma inside you. So for the detection of very early stage cancer or precancerous regions with NBI, there are two important findings. Very early stage cancers are presented as a well demarcated brownish area at the distant view. And they have abnormal microvascular proliferations at close view or magnified view. In other words, so this is the very early stage cancer. And it is presented as a well demarcated brownish area. The important thing is border is very clear. Border is traceable. And at the magnified view, we can check the shape of IPCLs. And as for the IPCL, there is a classification from type 1 to type 5N. And for the detection of early stage or precancerous lesions, important findings is this one. Type 5.1. So for the detection of early stage cancer, dilatation or meandering, irregular caliber, in other words. So this is the very early stage cancer. And it is presented as a well demarcated brownish area. The important thing is border is very clear. Border is traceable. And at the magnified view, we can check the shape of IPCLs. And as for the IPCL, there is a classification from type 1 to type 5N. And for the detection of early stage or precancerous lesions, important findings is this one, type 5.1. So for the detection of early stage cancer, dilatation or meandering, irregular caliber, or rebellious shapes. These findings are important for the detection of very early stage superficial cancers. Also, the posture or position of that is very important, but I was kept because Dr. Sugimoto has already mentioned about this. Briefly, for the normal observation of the larynx, sniffing position is very good. And when we want to check the hypopharyngeal extension of the laryngeal cancer, modified Killian position will be good. In this position, the hypopharynx will open like this, and it's very easy to check the hypopharyngeal extension. And also, when we want to check the vallecular or lingual surface of the epiglottis, and ask the patient to put the tongue anteriorly. Then vallecula will open, and we can observe this part well. So for the early detection of malignancies in NBI observation, positioning or posture is very important. And also, we need to observe the mucosa, not only from distant view, but also close view or magnified view. From here, I'm going to show two cases of laryngeal cancer. This case, glottic cancer, and under the wildlife observation, it's a little bit difficult to identify the lesion. But in the NBI, we can see the brownish area here. And at the close view, we can see small brown dots like this. And this was carcinoma inside you. The other case, in this case, it's more difficult to identify. In this case, in the NBI observation, we can see something here, brownish area here. And at the close view, we can see small brown dots like this. And this was also a carcinoma inside. Okay, from here, I'm gonna introduce the intraoperative application of narrowband imaging. And the transoral surgery for laryngeal tumor or laryngeal cancers has been tried from 19th century. And always well organized and developed by Steiner in 1970s as a transoral laser microsurgery. It's a very good procedure, but there were some difficulties in some cases. Technical difficulties. So to overcome the technical difficulties in transoral laser microsurgery, transoral video laryngoscopic surgery or transoral robotic surgery has been developed. And there was another option as a transoral surgery. And in Japan, endoscopic submucosal dissection for gastric cancer or esophageal cancer has been applied for head and neck in the early 2000s. And from this technique, endoscopic laryngopharyngeal surgery, ERPS, was developed. And in my university, we prefer this procedure as a transoral option. And in general, to achieve the minimal invasive transoral surgery, first, precise evaluation of tumor extension will be important. And with the precise evaluation, we can reject the lesions with minimal margins, and we can achieve the function preserving treatment. And for the precise evaluation of the tumor extension, NBI is very useful. From here, I'm going to show 3 cases of laryngeal cancers. This is 66 years old male with glottic cancer. The cancer was located at the lingual surface of the epiglottis. So in the wildlife observation, it's very difficult to identify the lesion, but in the NBI, we can see small brown dots like this. And we can identify the malignant regions. And in the transoral surgery, we always double check with iodine staining. With iodine staining, the lesion was present as unstained area like this. And according to the findings of NBI and iodine staining, we put the marks with minimum margins, like 1 or 2 millimeter margins, and rejected it with minimum margins. So in this case, in the white light observation, it's a little bit difficult to identify the lesion. But in the NBI, we can identify the lesion because there are small brown dots, abnormal IPCLs like this. And we can double check with iodine staining. And reject the lesion with minimal margins. This is a rejected specimen. It was squamous cell carcinoma in situ, and margin was negative. 1 year after the operation, although there was a small perforation in the epiglottis, but patient complained nothing. Next case is a 72 years old male with proglottic cancer. In the NBI observation, we can see brownish area here. But under the white light observation, it's a little bit difficult. And at the cross view or a magnified view, we can see small dots, abnormal IPCLs like this. So we put the marks according to the NBI findings, and we also tried iodine staining in this case, but I will show you later. So we tried iodine staining, but at the laryngeal surface of epiglottis, this part, iodine staining doesn't work because in this part, there is less glycogen. So iodine staining doesn't work. Everything remains unstained, so it doesn't work. This is the white light observation. Here is a little bit reddish area here. And in the NBI observation, there is a brownish area, and at the close view, magnified view, we can see small dots, abnormal increased IPCLs, and with iodine staining, everything remained unstained, so it was not effective in this case. And the tumor was rejected with minimum margins like this. This is a rejected specimen, squamous carcinoma in situ, and margin was negative. And 1 year after the operation, no recurrence was observed. And the final case, 72 years old male with proglottic T2 cancer. So in this case, to identify the lesion is very easy because it's invasive cancer. But we use NBI to evaluate the margin. So here we can see small dots like this. And after the iodine staining, this part was not stained. So according to the findings of NBI and iodine staining, we can put marks, and we can reject the lesion with minimum margins. So in this case, we rejected the tumor with the cartilage like this. This is a rejected specimen, squamous cell carcinoma, and vascular invasion was not identified, and surgical margin was negative. Because this patient was 72 years old, a little bit old guy, and there was a salivas after the operation here, but so far patient complains no aspiration. So intraoperative evaluation using relevant imaging is very useful because we can obtain a very, very good exposure under general anesthesia. And we can evaluate the tumor extension very precisely. Sometimes we can find other lesions during the operation. And with a precise evaluation of tumor extension, we can reject the lesions with minimum surgical margins. And as long as the lesion is superficial, we believe that no frozen section is needed. And as for the laryngeal surface of epiglottis, so basically during the transoral surgery, we double check the tumor extension by iodine staining, but regarding the laryngeal surface of epiglottis, iodine staining doesn't work. Everything is not stained with iodine because of rest glycogen. So NBI would be the only alternative. So finally, I'd like to show some images of laryngeal lesions. This is a case of leukoplaky. So very, very small low-grade dysplasia. In the NBI observation, it's very clear. It's very easy to identify because of contrast enhancement. Here's the other case with low-grade dysplasia, very, very thin region. Also in this case, with NBI observation, it's very clear, it's very easy to identify. Also, NBI is useful to detect the vascular lesions, like polyp with ectasia, or this is a venous malformation. So these vascular lesions are presented as dark green lesions by relevant imaging. This is a case of papillomatosis. So here is a papillomatosis. Papillomatosis is presented as there is a increased IPCLs in the surface within the shimmering pale whitish mass like this. And NBI observation is useful for the multiple lesions. I mean, in this case, this is a granulation, but here is a small papillomatosis here. And with the white light observation, sometimes it's difficult to identify. But in the NBI observation, we can see small dots, small brown dots like this. So we can identify multiple lesions like this. And from here, I'm going to show some confusing findings. This is a case of, this is a case of irradiated mucosa. And irradiated mucosa, we can see here includes vascular structures like this, but no brownish area. Next case, this is a case. Yeah, my resident often misdiagnose these lesions. Oh, sorry. I think this is the piriform sinus, and there is a brownish area like this. But at the close view, the margin is not clear, border is not clear, and we cannot see the abnormal increased IPCLs. This is a lymphoid follicle or inflammation. Plurimarginated brownish area without abnormal microvascular proliferations. This is a case of, in this case, there is a brownish area under the white light observation. And other case, here is a brownish area. Here. This case, at the close view, no abnormal IPCLs. This is melanosis. Brownish area under white light observation, but there is no abnormal microvascular proliferations. So sometimes there is confusing cases, but important findings is the superficial cancer or cancerous regions like high-grade dysplasia are presented as a well-demarcated brownish area at distant view. And there are abnormal increased IPCLs at the close view or magnified view. These findings are very important. So finally, I'm gonna talk about the application of NBI in swallowing test. So maybe it is not the intended use of NBI for the Olympus, but recently it is reported that NBI is very useful in swallowing test. And the swallowing test, green color water is often used. And in the NBI observation, it is turned out to be red like this. So for example, in this case, there is a laryngeal penetration, but it's a little bit difficult to identify under the white light observation. But in the NBI, it's very clear. And also in this case, the subglottic area is a little bit dark and it's difficult to identify the green color. But in the NBI observation, we can confirm the oscillation very clearly. So NBI enhances the detection of penetration and aspiration in swallowing test. And so this is the last slide. I've talked about the application of non-relevant imaging in laryngology. NBI is a promising tool which enables early detection and precise evaluation of laryngeal regions. Again, I'd like to emphasize. So important findings is that the superficial cancer or early cancer or high-grade dysplasia are presented as a well-demarcated brownish area at the distant view. And if you find brownish area, you should check at the close view or magnified view to check whether there is an abnormal IPCLs or not. So it would be helpful to find the early cancers. Okay, thank you very much for your attention.
Thank you very much, Dr. Yo. Thanks for your excellent talk in the NBI in laryngology. So we will leave the question to the Q&A section, and every attendees, if you have any question, you can just type in the Q&A again. So the next topic will be by Dr. John Lee. So after a few sections on NBI in hypopharynx, nasopharynx, and the larynx, so totally we'll talk about laser application in laryngology. Thanks, John.
Thank you, Eddie. Let me share my slide now.
Yes, please.
Okay, just for 3 seconds, and then can you see the slides now?
Yes.
Yes, thank you. Yes, so thank you for the speakers. It was a nice presentation about narrowband imaging and malignant lesions in NP, hypopharynx, and larynx. And now I'd like to change the topic around to laser wavelengths in benign laryngeal lesions, treating in the in-office, i.e. awake patient setting. So disclosure, I have no financial interest in any company mentioned. Lasers are powerful instruments, and then they can, the potential clinical treatment tools, but then they can also harm the patient as well. At the end, I'll show my personal application, which will also differ from your attendings that you're at your hometown. Objective for today's presentation will be just providing some very basic using laser physics, and then introduction of laser options in in-office laser procedures and the settings, and to review the setup, and also application on benign laryngeal pathology, my experience. So the introduction would be after Satel in 2004, who has treated recurrent respiratory papillomatosis with laser at in-office setting, and then plus with high definition chip on laryngoscopic tips and laser fiber, treating laryngeal lesions in office with laser were widespreadly used by elsewhere in the Western countries. There are lots of benefits. Recent years has been published lots of journals mentioning about lowering the morbidities, patients' inconvenience, and also associated costs in the GA setting theaters. So the acronym for laser, it is light amplification by stimulated emission of radiation. So again, this is a sort of wavelength, but then we use different wavelengths, different chromophores to treat the lesions. Basic of the lasers are monochromic, where it's only one color. In coherent meaning the wavelength is the same in all phases of the laser. Is collimated, which is the lasers are all in parallel wavelength, and it treats parallelly. With that, it does not diverge. The wavelength would not get to other directions. So this is an important slide for treating the lesion. So the irradiated lesion depends on the wavelength, the power of the laser, the exposure time of the laser, and the tissue characteristic. And then once the laser has hit the tissue surface, of course, there's the tissue necrosis. And then the next layer, the red layer, will be a coagulation of the tissue. And then the next layer, the green layer, there will be some edema. So what is a short wavelength or wave pulse? It means that the energy in between that wavelength is smaller, as shown in the graph B. And then the pulse duration, which is between two peaks of the wavelength. This will be mentioned in the other slides and also in the laser settings as well. So in basic, shorter pulse would just generate lesser injury to the tissue. A longer pulse would cause a lot of injury to the tissue, with also other adjacent tissue swellings and edema. So this is size of the laser. As this diagram shows, that with a smaller size 2 mm beam profile, the reddish color has been very intensely increased in the middle. But then once the laser size beam has increased by 1 mm, the reddish color has gone down a lot. So i.e. the same energy which is dispersed in the larger area could reduce the injury of the soft tissues. These are the basic laser variables. So you have to know that energy, they calculate joules, power is equal to energy over time. And we use watts here. The spot size as mentioned depends on the fiber size. It could be 300 to 400 micrometers. So power density, as I mentioned in the previous slide, means the power over the area, the spot size. So it's watts over cm squared. Exposure time would be the time of the laser that's been exposed in the tissue, which will be mentioned later on. And the fluency, energy over time as well by joules over cm squared. So laser choices for in-office laser procedures are mainly for photoangiolytic, which means targets the hemoglobin. We use KTP mostly, or pulse style laser. For the cutting property, we use carbon dioxide laser. And now there's a new laser which combines both of the properties, which is a blue laser, which is in the 445 nanometer laser. Other lasers we are aware of would be NDI, 1060 nanometer, Holmium Yark, Erbium Yark, which also the Holmium Yark and Erbium Yark targets water as a chromophore. So it has a cutting property. So NDI would be a pigment targets a pigmented tissue, which is angiolytic, or maybe to target onto the melanins or hemoglobin as well. Wavelengths, as you see, KTP is at the 532 nanometers on the left side. It targets the hemoglobin, oxyhemoglobin, and the hemoglobin more than the water. So it peaks at the hemoglobin. So the energy is actually absorbed by the hemoglobin. If you look at the right side, the carbon dioxide wavelength, 10600 nanometer, it targets the water. So the peak wavelength would be absorbed mainly by the water. As you can see in this diagram, the left top would be the arc blue laser. The right top would be the KTP laser machine. And then all the way down from to the bottom is a CO2 laser machine. The left side has no fiber, but the newest version of the CO2 laser, the bottom right one has a laser fiber equipped with it. So the laser setting. I use mainly the CO2 machine and the blue laser. So this is a luminous CO2 machine. As you can see on the left side, the dial, there's a continuous pulse which has not been highlighted. The highlighted one would be a super pulse, which means the pulse width is smaller. So then therefore the energy exerted onto the soft tissue is much lesser in injury purpose. The bottom dial shows a repeated, single, and continuous. It just means that the laser could be repeatedly shot by the machine, or it just continuously applied onto the soft tissue. So for the repeated one, we always have to have the setting of the on time. On time would be the pulse length, which should be less than maybe 0.3 seconds. And then the off time would be the time where there's no laser applied to it. Hopefully, this should be set more than 0.3 seconds, where then there has a time where then the soft tissue can relax and the heat could dissipate it, so that the energy would be lesser. And then the most bottom left would be the power that you use. Although the machine recommends 10 watts, we always use CO2 laser around 4 to 5 watts. This is the blue laser. It also has the same setting. The 10 watts would be the power. And then on the left side, there's 46, which is the on time. but then we set around to 30 to 50 milliseconds, and then the off time would be more than 300 seconds, where then the patient, the tissue have time to have rest for the energy dissipation. So the next topic would be in-office laser procedures. So this, I again have mentioned that it can avoid the morbidity associated by the GA, either ischemic heart or stroke. And then if there's any risk for the suspension laryngoscopy, like long teeth, upper denture, unable to open the mouth that wide, thick neck, fat neck, unable to hyperextend the neck. This also could be, these are the patients where in-office laser procedure will benefit for them. So case selection, mostly wide range of benign laryngology disease could be applied on, i.e. telangiectasia, recurrent respiratory papillomatosis, vocal polyps, granulomas, Ranke's edema. In the Western country, they also treat some early laryngeal tumors, but in my experience, I just treat the benign lesions. Patient choice would be the most important case selection. The patient has to want to use inpatient wake technique. And then I'll recommend you to start off with benign lesions if you're trying to use in-office laser procedure. And then you have to also find a patient that could be still for at least 15 minutes. And if the patient has a high risk of for the general anesthesia, these are also cases for LA awake laryngeal procedures. Contraindication, as I mentioned, if the patient is intolerant to the office scope, i.e. when you're doing the scope during the office, they have severe gagging, these patients are contraindications. Or the patient is anxious while you're doing your flexible laryngoscopy during your consultation, these patients are contraindication as well. Once you put the scope in, you can't even see the larynx, maybe due to the epiglottis obscuring, despite any neck maneuvers, then these patients are not good for the procedure. Poor lung function, lesions are too bulky for laser excision, and uncontrolled hypertension at home, or allergic to lignocaine, recent heart disease, unable to understand your native languages. These are the patients that you should not expose them to the in-office laryngeal procedures. So with coronavirus era, we have to know that this is an aerosol generating procedure. And then we had to have adequate personal protective equipment, i.e. N95 mask and waterproof apron, hair protector, eye protector, and then the room should be well ventilated. We in our center, we use deep throat saliva tests to test the patient within the 72 hours period. We also perform this within our LA local anesthesia OT room with a negative pressure and heptofilter unit, and also with fresh cart and defibrillator nearby in the LA theater. So for documentation, hopefully these are well documented, i.e. they should we should take an informed consent, and then also vital signs in pre, intra, and post procedures. Chart the local anesthesia dosage using the nasal, oral, or laryngopharynx routes. And then for the laser, we have to jot down the NG per pulse use, pulse width, pulse per second, and total time as well. It is recommended that the patient don't drink after an hour, within an hour after procedure. Sort of setup. Depending on your personal preferences, you can set up your own preferences. My preferences would be having the video trolley in front of me, just right in front of the patient, so that I can see the TV monitor and the patient at the same time. I'll put the laser machine on the left side and the dual suction on my right side, and my local anesthesia tray on my left side, just next to my laser machine as well. And then the laser settings, it depends on your machine that you use. We use low setting for, let's say, CO2 laser would be low setting in 4 watts, where then there's only cutting property. For blue laser, we'll use around 3 watts for coagulation, and then 10 watts for cutting property. And then how to start up and how to set the thing. We have to teach the nurses how to help us. There should always be laser safety precautions like door signets and then laser glasses for every different wavelength. So one glasses might not suit for both of the laser that you use in your hometown. You have to know where the crash cart is, the location. Hopefully it's within 100 meters or within the room. And then sanitized topical anesthetic tray, which is labeled with what you use. I use mostly 1% lignocaine. This is a laser signet. We have to show what class's laser is. What class 4 is a laser where that it could hurt your skin and your eye. And then you always have to have laser protective eyewear. This is the classification. As I mentioned, class 4 would be unsafe for the eyes and the skin. Class 3 would be unsafe for the eye, and then generally safe for the skin. And class 2 would be okay with just without any with the suitable safety goggles. Class 1 is just safe to eyes and the skin. So again, don't forget that every goggles is for particular wavelength. So you can't use one goggle for all the wavelengths that you use in your laser machines. You should always have a laser checklist so that you should check if the doors are closed, if all the windows blinds are down, if there's a warning light on, so that when you're having your laser procedure, light should be on. Any if it's in GA, you should have a saline syringe ready so that if there's on fire, if there's laser fire, you can put them down. And everyone, including the patient, should have a safety glasses or goggle on. The next topic would be the anesthesia that I use. So mainly I use cofenacaine. This is lignocaine with phenylephrine, which is a vasoconstrictor. The lignocaine percentage would be the lignocaine concentration would be 5 mg per spray. 10% lignocaine. I'm sorry. The cofenacaine would be used in the nose. Yeah. The 10% xylocaine would be used in the oropharynx, which each spray there's 10 milligram lignocaine, and then the company suggests not to use up to 20 sprays. Maximum dose will be 20 sprays, which is 200 mg of lignocaine. So how do you do the xylocaine spray in the oropharynx? Firstly, it will be squirted in the soft palate, then to the lateral side, i.e. the tonsil pillars on the left and the right side. Then I'll also spray some into larynx and hypopharynx. So I have to bend that nozzle 90 degrees, and I use a tongue depressor, and then ask them to the patient to say E, and I'll spray a few more there. So after the SARS, the severe acute respiratory syndrome in Hong Kong more than 10 years ago, we don't have any nebulizer or mist inhaled lignocaine in our local hospital to be used. So I just spray cofenacaine, 3 sprays on each side. So there's a total of 6 sprays, which is 30 mg of lignocaine. Oral cavity, I'll spray 1 in the soft palate, and then 1 onto the left and right pillar, which is 3 sprays, and then 3 more sprays in the oropharyngeal, hypopharynx, and larynx, which makes 60 mg. And then I'll do flushing of the 1% lignocaine with the channeled endoscope, in total 10 mils into larynx, which makes 100 mg, which now total makes up to around 190 mg in total. Then wait for 15 minutes or more. Then I'll gently palpate epiglottis and arytenoid by the endoscope to check if the local anesthesia is working before I start the procedure. So adverse effect of this procedure, mostly accounted by laryngologists outside in the Western countries. It was only minor complication, which are anxiety, intolerance of the procedure, gagging, coughing, vomiting, vasovagal attacks, and discomfort and pain. There's less likely major complication being noted by the laryngologists in the Western country, like lignocaine, toxicity, methemoglobin, or laryngospasm. So there was a paper out in 2018, which has been, in-office laryngeal procedure has been performed for more than 150 patients. There's no major complications been noted. Minor complication was only vasovagal, which was only 4.1%, and no bleeding. And then the intolerance rate was 13.1%. So adverse effect, I'd like to show you this paper, which is done by the British Thoracic Society, and it's accredited by the NICE, was that for topical anesthesia, they recommend not to use more than 490 to 630 mg, which is 4 to 7 mg per kilogram of patient. When you go up to date website, they recommend only 5 mg per kilogram. So I do want to talk about the lignocaine toxicity as it is a major complication. Once you have patient having slurred speech, difficult speech, altered central nervous system, i.e. drowsiness, dizziness, muscle twitching, seizure, you should always call for help or the resuscitation team at your hospital. Then give the patient 100% oxygen, and then diazepam 2 to 10 mg to suppress the seizure, and then the patient has to have ICU care. But then toxicity on topical anesthesia, very, very rare. Methemoglobin. So it's very rare in lignocaine usage. It's more frequent with benzocaine usage. Mostly mild cases where then there's only cyanosis or chocolatey skin color. Oxygen supplement is enough, and then after 20 hours it should improve. But severe case, there's 1% that's been noted by the journal done outside. So therefore, what is the sign would be dyspnea, dizziness, tachycardia, and then seizure and hypoxia. This means that the patient has a high percentage of methemoglobin. The management would be giving a vial of 1% methylene blue. So you just take a vial of methylene blue and just IV inject it to the patient when they have these severe symptoms. Laryngospasm. There's no laryngospasm being mentioned by laryngologists who performs in-office laryngeal procedure, but it's mainly noted by the anesthetist, where then the patient is in a light general anesthesis. So what is the symptom? It will have crowing noise when there's no airway sound being observable. You use a stethoscope. There's hypoxia, and then increase in carbon dioxide, and increase in potassium as well. So what's your management? It'll be giving 100% oxygen, and then try to visualize the larynx with the laryngoscope that you have, and then do a jaw thrust. That's all. And if you have continuous positive air pressure or any an invasive ventilator, you can also give the patient. If you have propofol in your crash trolley or succinylcholine in crash trolley, and you are capable of using these drugs, do give them as well. But then if you don't, wait for the crash call anesthesis, and then to prepare the patient to be intubated if they do have laryngeal spasm. So limiting factor for the inter-office laryngeal procedure will be the cost of the fiber in our locality, and then some certain region in the world, this technology may not be approved to be used in the wake setting, or maybe in the office as well. And then some surgeon might be concerned of the poor hemostasis property of the laser. So they might, and then the patient's having unprotected airway in the office setting, they might not be very leaning forward to using in-office laser procedure. So now this is my experience of how I perform these procedures. Laser choice will be will depend on every surgeon's preference. You have to know which kind of properties you want. Is it a cutting property or the hemostasis property? So what I use is blue laser. This was because after the introduction by Professor Hess in German in 2018, he uses blue laser to demonstrate that as a blending property of cutting and a hemostasis property, but in the lab wise and in the human in the trial he did say that there was a good property of hemostasis and also cutting as well. And then he noted that there was a increase in absorption of the hemoglobin by 10 times more than KTP as well. So you can screen cap this photo. This is a diagram demonstrating how to maneuver the patient's head to have a better visualization of the larynx. So just a basic briefing of this maneuver is just moving the head to the opposite side to view the contralateral side. This is actually taken by the pamphlet published by Olympus and Professor Hess in office laryngeal procedure. So you can go online and then search Olympus and in office laryngeal procedure. You'll find this pamphlet. And then this is a video of personal experience on recurrent respiratory papillomatus. This was started at GA first, general anesthesia first. So I'll use the blue laser to just seal off the feeding vessel to the papillomatosis mass. And then I will just go through with 3 watts, 4 watts laser energy, and then use a 10 watt to cut the laser, the lesion. This is a fast forwarded for 4 times, so I don't move that fast. But then because this is only a one-hand procedure, so there will be lots of charring because there's no retraction. I'll use the laser fiber to retract a bit and then shoot the laser a bit. And then now at the end, I'll just cut it off and then use my laryngeal forceps to remove the lesion for biopsy and for sectioning as well. The next video will be a wake procedure. It is a vocal cord sits on the right side. And then I will, again, because of the low energy, I'm using 3 watts. I was trying to also kill off the feeding vessel. After 2 minutes, it didn't work. So I increased the laser power to 10 watts. Then the lesion started to chart again. So by that, I continue for around 15 minutes. Then the cyst has been flattened down by the laser already. For this lesion, there was no biopsy taken because it was just vaporized, seeing the lesion for hoarseness of voice. This took around 20 minutes, for the whole procedure. 3 months later, heals well, and then the patient's happy with the voice. Then the next one would be a laryngeal granuloma, which was presented with a hoarseness of voice, and I had a excision before in GA, and then recurred 6 weeks later. So we offered him a laser procedure, and we did a laser excision with 10 watts. Shows there's lots of beating, but then after suction, it's clear again. Then we continue with the 10 watt laser. It took longer time for this patient because it was a large lesion. It was 30 minutes. Then we just took a biopsy from the papillomatus, sent it off, and this is the end lesion. Then the same session, I gave a steroid injection for the patient. And 8 weeks later, I repeated the lesion. There's only some granulomatous over the arytenoid area, just a few shots for the killing off the feeding vessel, and then the remaining residue of granuloma. And that was just 2 weeks ago. So there was no latest photo for this patient at this moment. But 6 weeks later, the granuloma has actually gone down to just a minimal lesion over the arytenoid. The last one is actually focal cord injection that I use. I'll bend the needle 45 degrees and then do a one-hand technique, and then put the needle into the cricothyroid membrane by the assistance of the endoscope, and then you see the needle coming in the tracheal lumen. Then I'll aim it to the lesion, which is the focal cord palsy, which is on the left side, and then inject it underneath the focal cord. This was a submucosal injection, so you can see that this is the radius I use. This is another patient, which I injected laterally to the focal cord, and you can see the ventricle filling up now. Yeah. This video is just for the introduction to our workshop in the afternoon for the applicants. So we will also do that later on this evening. So that's the end of the presentation. Thank you very much.
Thank you, John. Thank you, Dr. Lee. So we have finished all the talks for this morning, and now we'll have a test for everyone so that let's see how many things you have learned from the previous talk. So we'll start the polling system. There is the MCQ. So you have tried your polling system before, and we are going to pose the question. So the first question is from Professor Sujimoto talk, and you have time to answer the question, and we'll discuss the answer afterward. So the first question is, which is the most effective way to detect early cancer of the posterior wall of oral pharynx using NBI? And the second question is, which of the following statement is incorrect for NBI application? And the third one is, which of the following is the correct color of the cancerous area observed by endoscope using NBI after iodine staining during transoral resection of pharyngeal cancer? So probably enough time for answer these three questions. Can we have the result? Okay, for the first question, which of them is the most effective way to detect early cancer of the posterior wall of the oral pharynx? So the correct answer is the modifying Killian position. Most of the attendees get the correct answer. So Professor Sujimoto, any comments? You have mute your mic. You have to unmute your microphone.
Sorry. Okay.
Yeah.
Okay.
Yes,
Thank you.
okay.
This is a question for the oropharyngeal posterior wall cancer. So not for the hypopharyngeal posterior cancer. So modified Killian method position and modified Killian method is very effective to detect the hypopharyngeal cancer in the deep portion of posterior wall. But this is a question for the oropharyngeal cancer. We should observe cancer from as vertical direction as possible. So especially in case of posterior wall of pharyngeal cancer, not from tangential. So the correct answer is observation from the mouth.
Oh,
Sorry.
so the highlighted one is just the most people answer, but it's not the correct answer. So the correct answer should be observation from the mouth. So only 22% of the candidate get correct. So thank you. So modified Killian is for hypopharynx. It's not for the cancer of oropharynx, right?
Yeah.
Okay. Next question. Which of the following statement is incorrect for NBI application? So the most frequent answer is NBI is useful for diagnosis early P16 tonsil cancer. Professor Shichimoto, which one is your answer?
Yeah, it's correct.
It's correct. Okay. So can you explain why?
Yeah. Number two, NBI is useful for diagnosis because in the cancer of early P16 positive tonsil cancer, the superficial mucous membrane is normal because P16 positive tonsil cancer arises from the deep portion of tonsil, inner cell.
So it's not like early mucosal lesion, right?
Yeah, we cannot detect early mucosal lesion.
And do you think that there is a lot of crypts in the tonsil? Is it also affect the screening of the
crypt from crypt? Yes.
Yeah, because some attendees also ask about whether NBI OGD is good for unknown primary. So as far as we know that a lot of unknown primary is actually from the oropharynx. So the limitation on the oropharynx actually make that NBI OGD is helpful, but not is very, very helpful in unknown primary, right?
Yeah.
That it may miss the unknown primary from the oropharynx. Yeah.
Even upper GI endoscope does work for the early stage P16 positive tonsil cancer.
Yes. Okay. So then we move to the third question. Which of the following is the correct color of the cancerous area observed by endoscope using NBI after iodine staining during transoral resection of pharyngeal cancer? So many people answer brown and silver metallic. So what is the correct answer?
Yeah, correct answer is silver metallic.
Silver metallic. Okay.
Yes, I presented it in the last slide.
Yeah.
And usually we can detect a cancer area as brownish dots. But we are using endoscope during operation, and after iodine staining, the cancer area is cancer area doesn't be stained and isn't stained, and waiting for a few minutes, the unstained area, the color of unstained area of the unstained area changes from whitish to pinkish. And after using an NBI endoscope, the color seems like silver metallic.
Okay, thank you.
Yeah.
So then we move to the polling for the MCQ quiz for the next talk. The next talk is by Dr. Jason Chen. It's on the NBI in the NP. So you have few minutes to answer the questions. And we will have the discussion and answer afterward. So for question 2, the first answer have some typo, should be EBVIJ instead of the FBV. Okay. So we will have 30 seconds more. So can we have the answer? Okay. So the first question is, which of the following statement is true? The first one, the first statement, nasopharyngeal carcinoma often present with blood-stained saliva, nasal secretion, or with a neck numb is the most popular answer. Jason, is it correct?
So the most popular answer is correct. I'll just go through the others. So nasopharyngeal carcinoma is not caused by HPV, it's caused by EBV. There have been some reports of co-finding of EBV and HPV, but we're not sure what that means at this point, but the causative agent is definitely EBV. Nasopharyngeal carcinoma does not often present with constitutional symptoms. So the most common is a neck lump, possibly with nasal symptoms and ear symptoms as well. The histological type from WHO most commonly is type 2 or 3. Type 1 is keratinizing, which is pretty rare. And being genetically Han Chinese is a risk factor for nasopharyngeal carcinoma.
Okay, thank you. So the second question is, nasopharyngeal carcinoma can be diagnosed by what kind of method? So all of the above is the most popular answer. Is it right?
Actually, it's none of the above. So the gold standard for the diagnosis is actually pathological diagnosis. So you need a biopsy. So EBV, viral capsule antigen, early antigen antibodies are definitely not diagnostic. EBV DNA is an interesting one. As a last resort, if a patient has something that looks like MPC on imaging, it's a submucosal lesion, you try multiple biopsies, you cannot get it, but they have a raised EBV DNA, then we may sometimes consider this being nasopharyngeal carcinoma. But the definitive diagnosis is typically still biopsy with EBA positive, Epstein-Barr RNA positivity on pathological slides with an undifferentiated carcinoma. Endoscopy guides you for biopsy and also possibility of diagnosis. And MRI also is a guide for diagnosis, but it's not a diagnostic tool. It's not definitive diagnostic tool.
So all the other technique basically just assist you to have the diagnosis, but the biopsy still is the gold standard for making the diagnosis of NPC.
Yes.
Oh, so we move to the third questions. NBI endoscopy of the nasopharynx can be used to detect abnormal blood vessel, which may indicate an underlying malignancy is the most popular answer. So what's your answer?
That's the correct answer. So for NBI, we typically use white light to detect a mass in the nasopharynx for a large adenoids or nasopharyngeal carcinoma. So NBI is for vasculature, it's not for the mass per se. And you can use both information together as a guide. And similarly for an ulcer, you can use white light to detect the ulcer mainly. And to delineate the clinical extent of a malignancy such as the nasopharynx, NBI has not been shown to be able to do that yet. There's all the data for primary NPC has just been for a diagnosis of NPC, but not to delineate the clinical extent of the malignant lesion in the nasopharynx. So that's not available yet. Particularly if you're trying to look into the phosphoresal, it can be very, very challenging at times. And so at this point, there is also no data to suggest that NBI is more sensitive or accurate than only white light endoscopy in the nasopharynx. The function of that may be because we're trained mostly to use white light during our endoscopy. We're not routinely trained to use NBI. That's one possibility. Also, we don't have a good delineation of the vascular changes in NPC at this point yet, which may be another function of why NBI is not as sensitive. But things are changing and do change quickly, particularly around technology. So we'll see how that transpires in the future.
Thank you, Jason. So then we move to the next questions. Is about the talk by Dr. Yo. It's about the NBI in larynx. Again, we have a few minutes to answer the questions, and there are 3 questions again. So we shall have 30 more seconds. So can we have the answer? Okay. So the first questions, in narrowband imaging observation, which finding is not suggestive of superficial cancer? So the most popular answer is the untraceable submucosal vessel. Yo, what is the answer?
Yep. Okay, the answer is B. So the superficial cancer or a very early stage cancer or pre-cancerous lesions are presented as a well demarcated branch area. So it has very clear border, traceable border. So B is the answer.
So B is the answer. Okay.
Yep.
So the next question is that in NBI observation, which findings of the IPCL is not suggestive of superficial cancer? So contraction is the most popular answer. And your answer?
Yep. The answer is A. So in the superficial cancers, the findings IPCLs include the dilatation of the IPCLs, not contraction, and dilatation and meandering, irregular caliber, and barrel shapes. These findings are suggestive of superficial cancers. So the answer is A.
Okay, thank you. So the last question is, iodine staining doesn't work well at which area? So the most popular answer is the laryngeal surface of the epiglottis.
Yes, that's right. So at the laryngeal surface of the epiglottis, everything is not stained because of rest glycogen. So in this part, iodine staining is not effective. The NBI observation will be useful in this part.
Yeah. So our upper GI surgeon is very reluctant to spray the glucose iodine in the laryngeal side. So they worry about the aspiration, the risk on pneumonitis. So what's your experience on that?
You mean during the operation? Or
yeah, during the operation. Yeah.
Because the patient is intubated, so it will be okay. We don't have any case of aspiration after the surgery.
But they will not spray it during the OGD, right?
During the
OGD examination?
No.
No, okay. So thank you, Yo. So we move to the next questions. So it should be the question about the laser application in laryngology. So can we have the question now? Yeah. So again, you have a few minutes to answer these 3 questions. So we shall have 30 seconds to go for the answer. So shall we have the answer? Yeah. So for the first questions, which of the following is a unique property of laser? coherent is the most popular answer. John, is it right?
Yes, it is right.
Okay, so it's just the property of the laser. So the second
Yes, what it is.
question is, which will not be a contraindication for awake laryngeal procedure. So most people choose aspirin 80 milligram. Is it correct?
Yes, it's correct because aspirin 80 milligram by experience in general head and neck procedure or any endoscopic procedure, it does not show that there's lots of bleeding and then it could be stopped by our laser. So it was not a contraindication. But if the patient has took aspirin 80 mg and you are a bit afraid of hemostasis, then if that aspirin was for prophylactic for arrhythmia or avoiding stroke or ischemic heart disease, then you can take it off for 7 days, and then you can still perform your awake laryngeal procedure.
Okay.
Otherwise,
So thank you. And the last question is: a 33-year-old male underwent a awake laser laryngeal procedure. A total of 160 milligram lignocaine was administered topically over nose and larynx. He complained of dizziness, tinnitus, and tremor. So which choices will be the management for him? So the popular management is all of the above. And your answer?
yes, because as I've mentioned, once that there are tremor, dizziness, you are scared of lignocaine toxicity. And with lignocaine toxicity, once it's diagnosed, the patient should go to ICU care for at least a day just to monitor the patient's vitals. So call for help, resuscitation team, and while waiting, give oxygen and also diazepam just to stop any seizure episode or attacks. So all of the above.
So as far as you know, is there any antidote for lignocaine toxicity?
At this moment, no. Let's see, no, I've not met, no, there's no antidote lignocaine toxicity. It has been, it should be under care with hyperkalemia just to, and should also lipid emulsive, lipid, lipid.
The intralipid should be the antidote
which has been
for the lignocaine toxicity.
Yes.
Okay. I think and also the seizure status is the late toxicity. So the earliest one will be the neurological,
yes,
the lip numbness, and then follow with the cardiovascular system.
Yeah. So slurs of speech, as I mentioned,
And so that's all for the MCQ quiz, and we can move to the Q&A. So I think most of the questions that raised by the attendee was answered by the speaker and also by Professor Tong. But basically, if we summarize all the questions, is that everybody is interested to set up their own NBI service. So can we share that what kind of technology that you require for the setup? From the video system, can we use just the outpatient video system, a simple one to do the NBI screening and then also the surgery? So Professor Sujimoto, what kind of video system you are using in your setup of the NBI? You use the ENT one or you use the upper GI endoscopy, the which kind of model?
In my outpatient clinic, I'm using ENT endoscope only. But
So as far as I know, the ENT endoscope is the small caliber one. So they go through the nose, but they don't have the magnifying function, right?
Yeah.
So is it very important for the magnification during the NBI procedures?
But magnifying endoscopy will be needed only in the during operation. I think ENT endoscopy is enough for the outpatient clinic.
So for screening, probably the nasal endoscope for the ENT endoscope is enough. But if you want to go for the operation, probably you need the magnification function from the upper GI surgeon.
Upper GI surgeon.
How about rigid scope and flexible scope? Are there any difference?
Sorry?
Rigid endoscope and the flexible endoscope, are they any different? You use rigid one or you use a flexible one to do the examination and the
flexible.
Flexible.
Flexible only.
Yo, how about in the
Yes.
larynx? You use flexible or rigid?
We use flexible.
Okay. Jason, in the nasopharynx? You mute your microphone.
It's used. We use flexible as well for the nasopharynx mainly. We don't use the rigid application. I
Okay.
just want to supplement, I guess, what Professor Sugimoto was mentioned. I think there's a lot of difference in practices. I think in Japan with Yo and Professor Sugimoto, the use of NBI is much higher than we use, I would say, here or elsewhere in their routine practice. So I think your experience with NBI is much more, and you are able to probably see much more because you used it much earlier on in your career, whereas we've only just started using it more and more. So we're learning how to, I think, appreciate the NBI from the nasal endoscopes at this time point. So I think there's also a difference in terms of use of NBI around the region, and there is a learning curve to appreciating the differences on NBI, definitely.
So what kind of training you need to have your background except this APOST NBI course? So any training that we require to start the NBI screening, because to interpret the vessel changes under NBI, so the experience from the upper GI surgeon. So do we need to go to the endoscopy center and to work with them to see how's the application of NBI in the upper GI first? Because as Jason mentioned, that without magnification, so using the nasal endoscope to pick up an early lesion with an NBI technology in the upper aerodigestive tract is very difficult at the very beginning. So what kind of training that when you begin your service in your center? Do you go to do the NBI endoscopy together with the upper GI surgeon or do it together?
Can I talk?
Yeah.
In many cases, esophageal cancer exists with hypopharyngeal, oropharyngeal, and laryngal cancer. So I always consult to upper GI doctor to screen the esophageal cancer or stomach cancer, etc. So, and I ask them to screen the pharynx and larynx as well.
Yo, you also ask your endoscopist friends to screen the larynx?
Yeah, of course. So we have a good relationship with GI doctors. So we ask GI doctor to check the pharynx or larynx if possible. And also when I started these procedures, I went to GI department to learn the endoscopic findings. Otherwise, it's very difficult for the beginners to distinguish the lesion with NBI. So I learned a lot from GI doctors.
Yeah, I think that is the key point, that the first benches of cases really from the upper GI surgeon. So you have to talk with your upper GI endoscopist and ask them to screen the hypopharynx or the larynx when they screen the upper head neck cancer or the esophageal cancer survivor. So the first few benches of cases will come from there. And you have to learn from them how to use the NBI technology in the hypopharynx, because they have applied the NBI technology in the esophagus for a long time. So they have many experience. And if the ENT surgeon want to start, you need to talk with them and collaborate together to start the service. So one more question is that, how about the other technology? How about the pen test, eye scan? They also claim that they have a similar function to screen the early lesion and even the aspiration. So any experience on that? Yo, Do you have experience with?
We have Pentax system,
Mhm.
and it's also good. Basically, the technology is very similar, so it works well.
Okay. Taro?
I'm sorry, I will choose NBI or FICE.
Yeah, I think the data on NBI is more evidence on this use of to screen the early cancer. But as you mentioned, that there are other technology that may still be helpful. So if you have your other video system already, you may still try that kind of clinical application, but without the NBI. So there are other companies that do offer similar technology. So I saw most of the cases that just Professor Tsujimoto using in your cases is the Sato retractor, right? So this exposed the hypopharynx a lot. How about larynx? What kind of retractor you are using?
Well, it depends. Sometimes we use a normal. Sorry. And sometimes we use the normal laryngoscope, and so I mean straight type laryngoscope. But when we perform the surgery for the lesion at the lingual surface of epiglottis, I prefer Sato's laryngoscope.
So for the attendings, did Tsujimoto show the Sato laryngoscope on your presentation? I think it's a very curved laryngoscope that put in the anterior commissure that can expose the hypopharynx a lot. So to have a successful ESPL, you still need to have a good exposure. So if you cannot expose the lesion, most of the time you can just go for ESD only, because the endoscope have the energy device come from there. So, but if you want to start ELPS, you have to have a good exposure, and then you have the correct laryngoscope to expose the lesion. I think the Sato one is still currently the most helpful laryngoscope to expose the hypopharynx. So how about the energy device? So did I need to use an Olympus, Irby? Can I use a Valilab, or can I use other energy device to do the dissection? Taro?
Hi, I'm using KD 600 as an KD 600.
KT 600.
It means malleable needle type electrode knife.
So that is the electron knife. But what's the energy machine? The diaphragm machine.
Energy machine, electrode.
Is the Olympus or the Irby? Okay. Yeah. Yo?
Me too.
You also Irby?
Yeah, Irby.
Okay. Yeah, because we tried the Valilab, and the energy outcome is a little bit different, and you cannot have the dissection as good as the Olympus or the Irby one. So I think the energy device also make the difference. So you mentioned about your needle. Your needle is also from Olympus, right?
Yeah.
Yeah, and you also have your needle.
Yes.
Yeah. Okay. But for your information, it was not export from Japan. So the alternative is that some people use the arthroscopic diaphragm from Medtronic. So you can use, this is another option. It's the arthroscopic diaphragm. It has a curved and an insulated tip. So if you want to start your surface, but you don't have that Olympus needle, so you can start your ELPS with this Medtronic arthroscopic diaphragm. Okay. So cases. So that is all for early lesion, right? Only for severe dysphasia or at most T1 lesion. So many people ask about the margin. So is there any difference between the margin of a severe dysplasia and an early T1 lesion? Taro?
Yeah.
Any difference between a severe dysplasia and a T1 lesion in the hypopharynx when you perform ELPS?
Yeah. And we must think about the horizontal margin and the vertical margin. And
so circumferential margin you can assess with the NBI. Is quite sure that it was clear because of the very good visualization.
Yeah.
But how about the depth?
Depth.
Yeah.
During operation, recently we are using upper GI magnifying endoscope. NBI, using NBI. So, and we can see the surface vessel as B1, B2, and B3. And during I presented B1, B2, and B3 vessel during my presentation, and B1 and B2 means B1 or B2 part of B2 means very superficial cancer, and B2 and B3 indicates a little bit invasive cancer. So at the time of operation and first time of operation, after I identify the B3 vessel, I stopped to do transoral surgery, and I would like to choose induction chemotherapy. For example, TPF for 2 courses, and after that, I retry transoral surgery.
Also, if you detect a deep invasive lesion with V3 vexual patterns, so then you ask them to go for neoadjuvant chemotherapy first, and then come back to do the surgery.
Yeah.
So you basically just use the endoscope to assess the depth of the invasion. Is there any helpful from MRI or the endoscopic ultrasound to assess the depth of that early lesion?
Yeah. It is very difficult for us to detect the depth of invasion by CT and MRI. Very difficult for the small cancers.
How about EUS? The upper GI use EUS in the esophagus a lot. So any role for the EUS in the hypopharynx?
Hypopharynx. Sorry.
The endoscopic ultrasound assessment in hypopharynx. Any role or any experience on that?
Preoperative assessment.
Yeah, assessment of the depth of invasion.
Yeah. Preoperatively, we are using CT scan and MRI, and sometimes upper GI findings.
Okay.
Before operation.
Okay, thank you. Yo, how about you?
So you were asking about the ultrasound under the endoscope.
Yeah,
right?
yeah.
So
yeah.
I think it's an option, but I haven't tried it yet. So in my case, I usually try hydrodissection. I mean, inject the solution and check the depths. If the lesion comes up with the hydrodissection, we can reject it. But it attached to the bottom and it doesn't come up with the hydrodissection, we will quit.
Okay.
Stop surgery. Yeah.
Okay. How about the margin? So any margin between severe dysplasia or a carcinoma?
Actually, in my case, I always set the margin at around 1 or 2 millimeter. I think it's good enough. Because we can evaluate the extension very precisely.
Yeah.
To 1 or 2 millimeter would be enough.
For me, I usually 2 or 3 millimeter. 3 millimeter.
Okay. So thank you. So quite a lot of questions about the post-treatment screening for the NBI. So someone worry about that. Is it helpful after chemo irradiation? So the mucosa look different, or some people with previous surgery before, and we now go for NBI screening, can we still pick up the early recurrence?
Yes, sometimes. But after chemoradiotherapy, the mucous membrane is swollen in pharynx, so we cannot see the lesion not easily compared to the pre-CCRT. So I think it is very difficult to find early stage recurrent cancer like TS or T1. So if I think there is some recurrence in the pharynx or pharynx or hypopharynx, I will do surgery. I will check the lesion by general anesthesia using Sato.
Yo, in the larynx, how about in the larynx?
I agree. So now, as Dr. Sugimoto has mentioned, it's very difficult to distinguish the recurrent regions after the radiation. Sometimes we can, but sometimes we cannot detect it. It's very difficult to distinguish. Yeah.
How about in the nasopharynx, Jason?
I think also for recurrence, it's very difficult in the nasopharynx. I think it's a combination of factors. You already have some vascular changes. You have crusting. Our endoscopes don't have suction or irrigation to help with that. So I think, and also I think those factors make it challenging to use NBI in the recurrent setting.
So everyone use diaphragm to resect the ELPS. Can we combine the laser? So is it possible to use the laser to assist in the resections instead of using a diaphragm? So any people have the experience of combining NBI and then a laser, like a blue laser that John using or a CO2 laser. So is it possible?
I have the experience using CO2 laser, hollow fiber type. But
so what's the difference between
in case of a needle type electron knife, it was very difficult. It was very difficult to use. But I think CO2 hollow type fiber laser is useful for laryngeal cancer.
But hypopharynx is quite difficult.
I don't like it.
Okay, and Yo?
Yeah, in transoral laser microsurgery, we use CO2, but in the ELPS, I haven't tried it yet.
Even in the larynx, ELPS laryngeal lesion.
So usually we perform ELPS for the zebra-glottic cancer, and so far we don't need CO2. We can detect the lesion with electric cautery very easily. So I don't feel any advantages of using CO2 later.
And John, do you use the NBI to look at the vessel on your vocal cord lesion? Because sometimes I saw that on your video you cauterize the vessel before you proceed for the dissection. So if you switch to the NBI, will you show the vessel more clearly so that you can more precisely cauterize the vessel for your surgery?
Yes, it does help. So using the NBI could actually intensify the location of the vessels, and then I could aim more so then you can reduce soft tissue injury. And then about using it in a long, maybe a cancerous lesion, the only problem is that when the laser is at the end, because the laser only shoots in one direction, it does not turn. So once you're at the side, you want to laser off or excise the lateral walls, there's some difficulty. I mean, you can do it as a ESD, like the upper GI surgeon, use just use a traction and then shoot it on the side. But lots of people think that's very difficult to control. So as Professor Sukimoto said, that it's better for Laryngology because the Laryngology is in front of you, and then the laser just has to shoot at the laryngeal anatomy. Then that's easier than doing in hypopharynx. So I do agree with Professor Sukimoto saying that it might be difficult for lateral wall lesions that you have to excise. Yeah.
So thank you. So is there any more idea or questions or discussion want to raise by the panelists? So Jason, do you have any things to summarize or round up?
So no, I think I'd like to, I guess, thank everybody for participating, and Professor Sugimoto, Yo, Eddie, John for helping run this webinar today. Obviously, Kelvin and Bonnie behind the scenes. Professor Tong, who's helped answer a lot of the Q&A questions. He had to run off, but I think it's been a great talk. I think the summary in terms of NBI, it's a very, very useful tool in both diagnostics and also treatment, but you really have to use it. And to learn to use it, you do need to kind of shadow your GI surgeons who have a lot of experience with its use, and just communicate with them that you would like them to also look at the hypopharynx, oropharynx, and larynx during their OGDs, because they go past that area very, very quickly. Unless they're specifically looking in that area, they will miss. They won't look for things there. So you do need their support as well. And I think the equipment setup, most centers will already have in some ways. It's a matter of using what you have available for these particular procedures, and they are rewarding procedures, and you can really treat these patients well as well. And technology changes very fast, so I'm sure we'll see more endoscopes coming our way in the future in the small caliber size with better focal length and better magnifying capabilities as well. So that's in summary about the NBI course. And please don't forget to fill out the post-course evaluation as well for this webinar. So I'd like to thank again everybody for participating. So thank you.
Yeah, thanks for filling up the final evaluations. That is very important for the APOST to improve in the future. So we'll post the question here, and please answer it before you go. Thank you.
Thank you.
Thank you.
Thank you, everyone.
Bye bye.
Thank you, Jason.
Bye, Jason.
Bye.
Eddie.
Bye. Thank you. See you later.
Thank you.